headsets, then I think we can. There are some just outside. My name is Oliver Morgan. I work for the World Health Organization Hub for Pandemic and Epidemic Intelligence based in Berlin. Today we're going to have a session on transformative innovations in public health surveillance and intelligence. So if we can start with the slides, please. Great, thank you very much. I'll introduce our panelists in just a moment, but I just wanted to say just a couple of minutes about the WHO Hub in Berlin. It's a new enterprise for WHO. We started last year, so we're now coming to the end of our second year of operations. And if we go to the next slide, please. Sorry, I have the slide clicker. And the mission of the hub in Berlin is really to harness innovations in both laboratory science and data science to drive new approaches for public health surveillance. The world of public health surveillance is an extremely exciting moment where there's huge amounts of technology available for us to use in public health surveillance, but the process of transferring those innovations into practice is quite challenging. So the WHO Hub has been established with the support of the German government in order to achieve that mission. And we work globally, and so we work in all parts of the world to achieve this mission. So I'll just introduce our panelists. We have a range of panelists from all around the world. So I'd like to thank them in advance for those who've traveled some long distances to get here to spend some time with us. I'd like to start with Dr. Adriana Alfonso. Dr. Alfonso is a medical doctor with a specialization in health service administration, epidemiology, geriatrics, and gerontology. She has a master's degree in health business management and has worked for the Uruguay Ministry of Health for approximately 14 years in a range of different positions. And she's currently the director, the head of the surveillance department and head of communicable diseases for the Ministry of Health of Uruguay. Muchas gracias, Doctora Alfonso. Next, we have Patipat Susampao. He's a social entrepreneur from Thailand. He's a computer engineer and a public health practitioner. And he co-founded Open Dream, which is a digital technology social enterprise based in Bangkok. Patipat operates at the intersection of technology and public health on a range of different participatory disease surveillance systems at the rural community level of northeastern Thailand. He's also led the design and implementation of Dr. Me, which is Thailand's first personal healthcare app. Moving along, we have Dr. Karen Hogan, who's the head of laboratory partnerships at Concentric by Ginkgo, which is a private company in the United States. And she has experience in growing high-quality laboratory partnerships for monitoring pathogenesis. And Dr. Hogan holds a BSc in environmental biology and a PhD in ecology and evolutionary biology. I'd like to thank and welcome Dr. Monica Moya, who's a research fellow at the Center for Epidemic Response and Innovation, or CERI, at the Stellenbosch University in South Africa. And during the pandemic, Dr. Moya worked on SARS-CoV-2 variant detection and tracking within the Network for Genomic Surveillance in South Africa. Dr. Moya also co-leads the African Working Group for Climate-Amplified Diseases and Epidemics, CLIMAID, which is a consortium across a number of different African countries. And then our last panelist is Dr. William Valdez, who's a medical doctor with a master's degree in epidemiology and a doctorate in health sciences. He worked for the Peruvian Ministry of Health for over 15 years, but is now a senior technical advisor at Vital Strategies and provides assistance to governments across Latin America on the effective use of data and decision-making and policy-making. So welcome to the panelists. So we'll move now to a range of short presentations from each of the panelists and then move to a discussion section. So I'll start by inviting Dr. Alfonso to give the first presentation. Thank you.
Bueno, a ver. Iniciamos desde... So, let's get started. Could you show my presentation? There it is. Good. My apologies. Well, first of all, let me start by welcoming you to Uruguay. It's an honor to be receiving this festival of data in Uruguay with so many people coming and so many countries represented and also in this hall. So welcome. I hope you enjoy your stay in our country. We want you to feel very much at ease, and hopefully this will not be the last event organized in this region. So we're going to share this title, Transforming Innovations for the Surveillance and Intelligence on Public Health. This sounds very ambitious, but our intention today in Uruguay and representing my team, I want to tell you the lessons learned from the pandemic, because this situation during the pandemic, as we discussed with other people here in the audience, is an opportunity, not just a crisis. And we believe that we should look at it like that, because we have a great capacity installed, and it's up to us, as Dr. Morgan said just a few hours ago at a meeting, it's up to us to make the most of those capacities, because the world devoted resources that were originally meant for other purposes. But we learned a lot. So we must think of an alert scenario and for a global. So we must conduct surveillance and be alert and respond. This is a target population, 8 billion. It's not static. It's constantly moving. And the systems and whatever we do has to be thought of from a global vision. We have great challenges. If we had to choose but 3 here, we would say majorly that we have been working on these 3 issues. Human capital, or labor force, technology for health services, ICTs, and to make the most of the alert, preparedness, and response mechanisms. In Uruguay, what we want to share and what we brought to share with you of the lessons learned from the pandemic is 4 big aspects. By no means are they the only ones, but we wanted to highlight them and to share them, because for us, it's a breaking point, and we were left with installed capacity. So as we said just a few minutes ago, no countries had the capacity, the resources, and the labor force that would enable them to face the challenges posed by a pandemic. We had to learn to use the pandemic for that purpose. As a country, we called this technological tracking. In Uruguay, much of the population is close to mobile phones. And we call it technological tracking because through an SMS message, we managed to send a person. The person could receive an SMS, and that's a problem because today people use other platforms such as WhatsApp. But our ministry was in a position to send SMS. So the person at the time received a message telling them, you have been identified as a contact of such and such who's been positive to COVID. So how could we do that? Because the person that was positive for COVID was given the possibility to say, well, let me identify my contacts as such, such, and such. Of course, that had been agreed upon with those people. So it optimized the time to response with their healthcare providers. So through this tracking, they could talk to the healthcare services so the people could choose where to go to for the COVID swab without a need to go to the doctor to get a ticket so that they would be able to have the test done. So as a health measure, in the case of a pandemic, this made it easier for the healthcare services, optimizing their time to response. This technological tracking, of course, doesn't solve 100% of the problems, but it made it much easier because it reduced 40% of the burden that was tracking contacts. Uruguay also worked in these cross-sectional lines to degravitate and to improve the health services, considering the exposure and post-exposure of COVID people. One of them was tracking, but people, through apps, could choose and know what drugstores were validated or authorized to conduct rapid tests. So the Ministry of Health had the governance and the expertise through something that we call COVID of all the tests in the country and their results in such a way that the ministry could monitor in real time all the positive cases, either through antigen or PCR. So it was through that app that shortly after, through georeferencing, of course, if the person agreed and downloaded the app, so that app could not be used just for that, but also even going abroad, going to the border to identify as a contact and even to have the data available at hand, being able to show their epidemiologic status and their vaccination status. So remember that one of them was the labor force, but it's also important to invest on the good use of technology on other issues. Surveillance is not just receiving the so-called passive surveillance and waiting for data to come to you, but you have to go and seek for the data. So that is why the countries do event-based surveillance or rumor-based surveillance, but you have to optimize that rumor-based surveillance. And fortunately, the teams we invited today have used tools that have made it possible to systematize the way we use the epidemiological intelligence of this platform. For instance, EIOS. Uruguay was visited, and here we have the person who, again, we thank, because that puts us at the same level of other countries using this tool and detecting potential events that are important in terms of public health and consolidating this and being part of a global vision of the bionic intelligence. So you may be aware that we were not exempt from the situation that all the world went through. All the data systems we had, all of them collapsed in a way. In case of a pandemic, we all had resources, but nobody was ready to receive the volume of data and the speed at which that information had to be analyzed. But not only were the surveillance systems that had to be prepared to receive a greater volume and validity of processing, but there's another challenge that comes hand in hand with that, and it is that all the data sources that are scattered all over, that are many and very good, not necessarily did they connect to each other. So that is the concept of interoperability. Uruguay is working, and the pandemic has given us the possibility that through cooperation, as among many agencies and organizations, we're working to optimize that surveillance platform. We are moving in the direction of an integrated surveillance and comprehensive surveillance system for timely responses. So we wanted to know, for instance, how many people with COVID had been vaccinated earlier, how many vaccinated people had comorbidities. At the time, it was done by hand. But this platform will put us in a position where we'll be able to analyze that more in real time and optimizing resources. And finally, another aspect that has been very important and left us with a great learning, and we are very happy to say as professionals, is that during the pandemic, all the countries shared the data they had. We can say that in all the countries had the data at hand, and we didn't have serious constraints reaching the data. But and that is why we present NISU, NISU. This is something that Uruguay is developing. This is an initiative. It's a health intelligence node. Is much more than a watch, an observatory. We are working to make the data available for the rest of the colleagues, but we also want it to be an interagency cooperation instance in the broadest sense. So hopefully in the short time we'll be able to give you more information about this. Now, so where are we heading? We don't want to reiterate the benefits of this NISU is to facilitate partnerships and to contribute to the spirit of this node of health intelligence. Of course, we follow a plan. We are strongly committed to develop a repository. We are in the second and third quarter, and obviously open the doors for the practice communities. We are working, for instance, to launch an exercise of good practices at a national level. Therefore, we are moving toward a Center for Support for Decision Making on health policies, and that is why we wanted to share this experience, and hopefully it will be of benefit for all. So thank you again, and once again, welcome to Uruguay, and please go to those fingers there and take a picture of yourself. Thank you, Adriana. That was a very important summary, very interesting. Quite a vast work conducted by the Ministry of Health in Uruguay. And that was very interesting to see how you progress with NISU. Now, let me invite Patty Pat for his presentation. Thank you.
Sawadee krab. Can I get my slide, please? Okay. Good afternoon, everyone. My name is Patipat from Thailand. Today, I'm going to talk about how we can stop the next pandemic before it starts by transforming communities into disease detectives. Around 70% of the human diseases originated from animals. And in Southeast Asia, the close connection between backyard farms and homes raised the risk of disease like avian influenza, Nipah virus, or likely even COVID-19, jumping from animals to humans. COVID-19 shows us that traditional centralized disease surveillance systems can be too slow to detect early warning signs of outbreaks. And this prevents rapid response to contain their spread. We need to take a new approach if we want to get ahead of the next pandemic threat. So in Thailand, we have developed an open source toolkit called the One Health Toolkit, which combines digital technology, community volunteer networks, and governance structures to enable participatory disease surveillance. We train villagers and farmers to spot early sign of health issues in backyard animals like pigs, chicken, and cattle, we empower them to report this event through the mobile apps. The system analyzes the reported data to assess risk, and if the concerning event is detected, it can provide preliminary guidance to the reporter to take containment actions or disinfection actions like quarantine sick animals. The system can also alert the government agencies to coordinate a rapid response. This participatory approach has led to massive improvement in the time it takes to detect and respond to the outbreaks. Many events that would have gone unnoticed for several weeks or several months are now detected within 72 hours. Over 50% of the community start control measure within 12 hours after detection, and 90% have successfully contained the outbreak within just 4 weeks of the first case. Volunteers that working with us are motivated by protecting their families, their communities, their livelihoods, not monetary rewards. Of course, when we started this project back in 2014, we need to purchase mobile phones for some of the community members because, Android was version 4 and iPhone was iPhone 5. You know what I mean? It's not everyone back then got a smartphone. But after that, no monetary support was provided. One of the fun motivation that we have learned was we have to install Facebook alongside with our One Health Toolkit app to keep the elder happy and keep the elder connected with their family members so they know what the benefit of having a smartphone and subsequently keep using our app. The toolkit integrates into existing local government structure to coordinate response plans, and the technology strengthens early data collection and analysis. The toolkit is open source, so you can check it out at onehealthtoolkit.org. And detecting outbreak within 72 hours is actually fast, and for us, it's a major improvement. But how can we go faster? So we currently exploring an innovative approach. We are exploring the use of metagenomic sequencing of wastewater from animal pens to identify pathogen before the symptom appears. This is like checking for the sewage water to detect COVID-19 in the city before people get tested and show symptoms. But this time it's going to be in animals. Because we believe that if there are going to be a disease outbreak, wastewater from animal pens can contain some known pathogens and unknown pathogens that can help us perform risk analysis to prevent the pathogen spillover from animal to humans. So we are exploring this methodology and developing a deep learning model to help us identify the pathogen in animal wastewater faster and use this data to supplement the current participatory approach to improve the protection of animal and human life. If successful, this could revolutionize how we predict and prevent the pandemic globally. By combining community participation, government coordination, and cutting-edge technology, we hope that we can stop the next pandemic at animal-human interface before it happens. Thank you for listening, and ขอบคุณครับ
Great, thank you so much. It's very exciting to see the combination of working with communities as well as implementing the newest technology to identify outbreaks as quickly as possible. Next, I'll invite Karen to, I think, carry on some of the themes that Patipat also raised. Thanks very much, Karen.
quite short, so I hope you can see me over this podium. Really just taking away for today, I'd like you to, I'll introduce our company and what we're working on, but the three major takeaways are that we're in this for the long haul. We are not intending to just respond to pathogens, du jour, but really to set up systems that can be comprehensive. The second is that all of the work we do is in partnership. We don't endeavor to own the system end to end. We know that people who are working with the best technologies, the best solutions are the people we want to partner with. So I'm hoping today that I get a chance to talk to more of you about that. And then the third is that we're just a really curious group of individuals. And so we're constantly looking at new case studies, new ways to solve problems. So if you have some crazy idea, we might actually be working on it already with our R&D department or our data analytics teams. So welcome that. My colleague Karen, we only send Karens to conferences. My colleague Karen is in the audience and can speak about that as well. So we are a company, my name is Karen Hogan, and I'm with Ginkgo Bioworks. Ginkgo Bioworks has been around for about 15 years. We actually went public while I was working with the company. The major kind of business employment at Ginkgo is around cell engineer strain optimization for new therapeutics, new agricultural applications, and we're very proud of the fact that we have what we call a code base of about 3.8 billion gene sequences. So many medical countermeasure companies or industry partners come and use our platform to generate bioinnovation. So you might be asking yourself, what is Ginkgo doing in the biosecurity space? And what we're doing in the biosecurity space is making sure that we're good stewards of the technology that we're innovating, and had a long desire to make sure that we're surveilling biology in the world so that innovations are being used properly, not being hacked. And COVID, when it came along, felt like the time for us to build up those capabilities. I don't know if everybody remembers supply chain issues with PCR tests. We quickly pivoted our labs, our high throughput labs, to do next-gen sequencing COVID testing. And then we partnered with local laboratory partners when the supply chain caught up. I know I'm preaching to the choir here that COVID-19 is not a once-in-a-century pathogen outbreak. We have a team that looks at all of the data that we produce as an organization, as well as publicly available data, and applies risk modeling and forecasting. And by their calculations, we could expect in the next 25 years, somewhere between a 43 and 50% chance of another pathogen that hits COVID proportions. But one of our key messages here about solving kind of the earliest warning systems and building up those operating systems that are sustainable is that this isn't a given. We can actually start implementing mitigation risks earlier and earlier if we keep up this pervasive monitoring so that we actually avoid that outcome and we drastically drop that percentage probability. So all of you are here, you've all been working on this, especially from the data side. We feel very strongly that the three kind of pillars that need to be in place and should be put in place through collaboration and partnerships is a persistent and pervasive monitoring network that actually addresses quite tangibly the gaps in the data and where the biases exist, and make sure nodes are set up in those locations to get better sources. So things like animal monitoring, where many of the diseases of concern do have a zoonotic relationship. So can we get better with animal monitoring and then with passive environmental monitoring? We also have a really excellent bioinformatics and epidemiological modeling division. We'll be working with Google, and I'm happy to answer some questions on that, to build up LLM models and to work with AI to take advantage of the code base that we built in Ginkgo itself from the genetic engineering, as well as the information that we're gathering as a part of our biosecurity initiatives. And then we really want to prevent any kind of outbreak again, so that's working with public health officials, that's working with ministries of health, that's working with the national statistic bureaus to understand how the data can be used to help mitigate and make decision making. We do not make decisions, we produce data and we bring the best tools to that, but we don't actually create the policy. but we do sit with policymakers and with public health officials to help them do deep interrogation of the data and understand what it is signaling so that we can have better responses. We'll have a little bit of a chance, I think, today on the panel to talk about how we're using AI and thinking through with our digital biothreat intelligence system. Lots of amazing solutions out there. Bringing these systems together, I think, is key to the exponential stepwise function of what we can do with the data. But we look at traditional data sources, public data sources, and then have some proprietary algorithms. And then we have some private clients who generate data that we can feed into our epidemiological modeling, and then feed that back to public health officials in our partnerships. I'm really looking forward to deeper discussions. It's been really fruitful with the WHO folks and with others on this panel about how we can create those partnerships to accelerate that in the near term. I don't know about you, but I'm particularly worried about climate change and have 2 children, so I'm feeling really anxious about that. And I think that these types of collaborations can be fundamentally game-changing. So we're an end-to-end systems integrator, which is a fancy way of saying we'll take on the hairiest parts of actually getting data into databases, or we'll work with people who've already solved that. So we have experience setting up collections both in congregate settings, especially school settings. That was a big contribution we made in COVID. In airport settings, so traveler hubs, in agricultural settings. So we'll get out there. We have teams that will, be working in the rain to collect samples. And then we also work with technology manufacturers, looking at kind of the cutting edge new kits and reagents and solutions that are available. We'll work with them in our R&D department and transfer that knowledge out to our laboratory partners or other stakeholders. Our key function and key knowledge base is around sequencing, and so my team in particular will kind of codify that into standard operating procedures, go to laboratories who don't have that technology and train them, and then start to flow samples across that. So we're talking about, really like disease, 55 diseases, WHO importance we can implement in labs, and we do it really quickly. So we're talking about weeks, not years to do that. And then we provide data analytical tools to the extent that they're desired. I'll wrap it up because I know we're coming up on time. But the last kind of slides are just the integration of this data is what we're most excited about. So using wildlife to human spillover inputs, using mobility networks, so literally tracking where flights are coming and going, because that was a big contributor to COVID spread, moving to land borders and moving to other ways of travel. Animals are interesting because you can both survey at the farm, but you can also wash down trucks that move animals around and start to do surveillance in those locations. So that's the kind of things that we think about. And then we feed that into traditional disease spread models and pull that together for our partners to help create the risk analysis and modeling for their location. Really focus on local generation, local engagement, but fit it all together in a global map to understand how fast things can be transmitted from point to point across the globe. Our work to date has mostly focused in congregate settings and airports, but these are all of the places that we feel that Sentinel nodes should go. And we recognize that many of these have been overlooked, or the data that's coming out is from symptomatic cases, not from asymptomatic or early cases. And so we're really focused on that first mile. How can we constantly be surveilling to get that information? So things like, testing in abattoirs and, being in wastewater municipal systems, being out in the environment on surface waters, those are the things that we think through. Habitat destruction is a big one because that's an increase of zoonotic transfer probability. I'll end us on what we're doing with the CDC at the moment. We both work with the CDC around AI governance, so we're part of a consortia that's providing an industry perspective around AI governance. Most of our team members are former academics or public health officials, so we really kind of understand the challenges and the opportunities, frankly, in this space. But we've been working with the CDC with about 7 airports in the US and many more airports globally. We have passengers come off planes and they will submit nasal swabs voluntarily. We don't collect their date of birth or their name, but we do ask them to provide some demographic information, like where did your plane originate, or some other information on that side. But we also pull wastewater off of the aircraft directly, and we surveil that for pathogens as well and do advanced genomic sequencing and bioinformatics and epidemiological modeling. This becomes a virtuous cycle because we detect variants really early. With the latest BA.2.6, we were second in the US and fifth in the world through this program to detect it. Oftentimes our program will detect things about 45 days to up to 2 months, 3 months before it presents in a clinical setting. And that's really important for helping mobilize the logistics of supplies and staff and kind of the more expensive, more limited resources to respond. So it's become a very important signal for the CDC in the US. And we have quite a few participants. So it's interesting, as an American, we don't have as many Americans coming off wanting to participate in it, but in our global flights, lots of folks are willing to jump in and create this variant tracking because they understand the global impact of diseases. And this is everywhere that we're working and we're growing. So we'd really like to strengthen our presence in LATAM in particular, but we are all over the world and really working in partnership with the communities. I'll leave you on the note that when we get funding for the work that we do, we endeavor to keep it in the economies in which we're working with. So we work with local laboratory partners, we work with local staff, we provide training and help set up training pipelines for those communities. All of the work is as much as possible being done in the location where data is being collected. It worked really well when we were doing state programs for K-12. It helped us hear what the value proposition of monitoring was for the communities, which is a critical part of adoption of public health measures, and we're seeing it to this day. People are feeling safer, they feel more ownership, and they're more willing to participate. So we love working at the local level, but keeping the global perspective. So thank you very much. I hope I didn't take too much time.
Great, thank you very much, Karen. It's really exciting to see the different perspectives and approaches from Concentric, and I think it's really enriching our approach to global public health surveillance. So thank you very much for coming and sharing today. I'll invite Monica to join us, who's going to dive more into the world of pathogen genomics. Thanks very much, Monica.
Thank you. So I want to take you all on a journey of what it's been like working within our research group, CERI, Center for Epidemic Response and Innovation, that's housed within an academic institution, but we work very closely with public health labs. So the work that we've been doing over the past 4 years. So I want to take you back in time, to a time that was more complicated, when SARS-CoV-2 or the COVID virus first arose. So in early 2020, the National Health Laboratory Services of South Africa paired with 6 academic institutions to form the Network for Genomic Surveillance South Africa. And some view this really speedy and collective response to the pandemic as the key to South Africa's successful genomic surveillance of the virus. So within the NGS-SA, we would collect samples from patients and do the genomic sequencing of the virus. We would use our genomic data and couple that with patient metadata and epidemiological data. We would move that through our analytical workflows of genomic epidemiology, phylogenetics, and phylodynamics. And with these methods, we were really able to understand the spread and the distribution of the virus across the country. And we use that to inform outbreak investigations, but also public health responses at the local, national, but also global levels. This genomic surveillance program enabled us to identify and characterize first the beta variant of concern, which you can see in the top phylogenetic tree as the yellow clade. We also subsequently identified and characterized the Omicron variant of concern, shown there as the pink clade. We then also identified the BA.4 and BA.5 sublineages of Omicron. All of these really important VOCs were first identified in Southern Africa. Not only did we work within South Africa, but we also grew a continental scale network across African research groups, but also public health labs, where we work to sequence the virus locally within these local sequencing facilities, but also within our regional sequencing networks. We saw great investment from the Africa CDC and the WHO AFRO in increasing the genomic infrastructure, but also the skills for the genomic analyses throughout the course of the pandemic. And as a result, we really saw the number of African SARS-CoV-2 genomes just shoot through the roof over the pandemic from these investments. So on the back of the pandemic, we are now leveraging the continental network we've established, but also the global collaborators we've connected with to develop CliMaid, the Climate Amplified Diseases and Epidemics Consortium. So we recognize the need to leverage this infrastructure and the capacity building that was developed during the pandemic to pivot and respond to what we think is the next new threat: climate-sensitive diseases. So in CliMaid, we work to predict, track, and control climate-sensitive diseases. CliMaid began in early 2023. So I just wanted to highlight two of the projects that we've been working on within CliMaid Africa, so the continental kind of focused working group. We partnered with the Public Health Institute of Malawi to sequence cholera genomes from the devastating outbreak that they've been experiencing last year and early this year. It was through our genomic work that we managed to characterize the strain that caused the outbreak, which you can see in blue at the top of the phylogenetic tree. And we managed to identify that it was the same strain causing a large outbreak in Pakistan in 2022. So we managed to time the introduction of this strain from Pakistan into Malawi, which you can see in red on the figure on the left. And we also identified this really huge ramp up in cases and deaths, which you can see in blue and gray. It really coincided and corresponded with increased surface water or flooding that was happening in Malawi. So Malawi experienced extreme floods as well as Cyclone Freddy, and these were really the climatic triggers for this outbreak that they had experienced. And more recently, we are partnering with the Institute for Health Research, Epidemiological Surveillance and Training in Senegal, also known as ERISEF, to sequence dengue genomes in West Africa, so from Senegal and Burkina Faso specifically. So we are working with ERISEF to really understand the epidemic trajectory of dengue 2 in the West African region, and we are characterizing the geographic dispersal of the virus in that region. So with these two projects in mind, I really wanted to highlight how genomic surveillance and phylogenetic analysis within an integrative and collaborative landscape presents a really great opportunity for quick and accurate investigation of outbreaks that can be used to inform public health response locally, nationally, and globally. I would just like to acknowledge the big team that's involved in this work and our funders and partnering institutions. Thank you.
Great, thanks Monica. It's incredible the work that's happening across the African continent and the work that Seri is driving as well. So thanks very much for coming to share that with us. Y el próximo y el último es el doctor Valdés. William, por favor, pueden hacer su presentación del trabajo en Perú. Gracias.
Bien, buenas tardes con todos. Como mencionó Oliver, yo vengo del Vital Strategies, que es una organización global que tiene su sede en Nueva York y que forma parte de la iniciativa de datos para la salud de Bloomberg Philanthropies. En los siguientes minutos voy a comentarles sobre el trabajo que hemos venido colaborando y cooperando en países de Latinoamérica. Si bien es cierto, nuestra organización trabaja con países en todo el mundo, pero fundamentalmente la presentación la voy a centrar en este ámbito latinoamericano. Bien, hoy en día se conoce mucho sobre el enorme impacto que tuvo la pandemia COVID en las muertes alrededor del mundo, ¿no? Si bien es cierto, esto no fue muy conocido a inicios de la pandemia, fue todo un desafío y puso en prueba a los diversos sistemas de salud pública de los países. Se convirtió en un reto importante, ¿no? Y para los epidemiólogos que están muy acostumbrados a dar información, cifras, contar cuántos casos de COVID había, cuántos fallecidos, realmente fue todo una dificultad en los inicios de la pandemia, ¿no? Entonces, los sistemas empezaron digamos, conglomerarse, hubo mucha presión, muchos pacientes, y se tuvo que echar mano a los tradicionales sistemas de vigilancia. Pero aún así se tuvieron que recurrir a fuentes de datos no tan tradicionales, como son los registros de mortalidad basado en población, es decir, los sistemas de defunciones. Si bien es cierto, gran parte de los epidemiólogos conoce la base de datos de defunciones porque analiza información para la toma de decisiones, para hacer los estudios de análisis de situación de salud, para utilizarlo en un contexto epidémico en la cual se debería estar vigilando de una manera rutinaria estos datos, no estaban muy acostumbrados, ¿no? Entonces, este fue uno de los primeros desafíos que se enfrentaron en aquel momento, ¿no? Muchas organizaciones tuvieron que adecuar y contextualizar sus objetivos para centrarse y focalizarse en el apoyo hacia esta emergencia sanitaria, ¿no? Se tuvieron que hacer una serie de documentación técnica para ponerse en un modo tal que apoyemos todas las necesidades de información que se requería para hacer una vigilancia adecuada del COVID-19. Por nuestro lado, nuestra organización, en conjunto con muchas organizaciones globales, elaboraron muchos informes y notas técnicas para tratar de documentar y recoger elementos conceptuales de la clásica vigilancia epidemiológica. Éramos muy conscientes que en diversos países del mundo los sistemas de vigilancia no tenían un desarrollo homogéneo, la heterogeneidad, digamos, era parte del común denominador de los países, entonces se tenía que desarrollar herramientas que sean de fácil uso, pensando sobre todo en aquellos países en donde sus sistemas de vigilancia, digamos, adolecía de oportunidad de información, ¿no? Hemos visto en las anteriores presentaciones que uno de los retos importantes...
We have seen that one of the challenges is to get early information and detecting epidemics early. So they developed a number of tools and instruments, including this calculator of excess mortality developed in a software that is very well known by all epidemiologists, that is Excel, and through a number of algorithms, they decided to get the information of total deaths as a baseline and to see how the number of deaths along the weeks reflected whether there was an excess mortality. So algorithms were designed for decision making to be able to establish how the epidemic was progressing. In the next slides, I'm going to give you information about the experience working in 3 countries. And one is Peru, Colombia, and finally Paraguay. So You may be aware that Peru was one of the countries that has had one of the highest mortality rates due to COVID-19. In Peru, before the pandemic, we collaborated, strengthening the vital statistics systems in the country together with the Ministry of Health and the civil registers to an extent that improved coverage and the access to quality data about deaths. To a certain extent, this made it easier than once these tools were published to monitor the excess mortality, Peru could implement it because in the system they were already gathering data and they could get data of total deaths, overall deaths on a daily basis. These results of the calculator were gathered very quickly in the surveillance systems, and they were integrated into the different platforms that were created at the time because of COVID pandemic. So as part of these results, and maybe in many other countries this was also seen, we used health intelligence as such, analyzing data on real time for decision making, and there were communicates to the population. There was a lot of pressure by the media and the population as such to know what was happening with the pandemic. In addition, it was also an input to establish a number of actions for quarantine in a number of geographical places in the country, or to release from the quarantine. This was one of the things that was used at that time. And as in Peru, in Colombia, we also worked. Colombia was a focal point for this initiative. We collaborated with them to strengthen the civil registry and the deaths, and they also had a system. So to a certain extent, that was helpful in implementing this. As part of that, we managed to use these centers of operations and trying to make decisions in real time, analyzing the context of the work but for the epidemic that was occurring at the time. Finally, in Paraguay, contrary to what happened in Peru and Colombia, Paraguay received support by a global grants system program, and the excess mortality was measured later, not initially, early on in the pandemic as in the other countries. So the work there had to be very in close collaboration between the Ministry of Health and the Statistic Institute, so that the health teams could, as a routine, analyze the mortality data. And when they received support, they could implement the surveillance of excess mortality rates, trying to relate that with, as you can see there on the slide, to establish scenarios. And the next steps, and with this finished, basically one of the big challenges was to integrate the surveillance to mortality, to the range of diseases that are subject to surveillance, trying to see the effect of COVID-19 in the overall death patterns. And this is key because this will enable us to have information, timely information, for to be able to monitor mortality, and to use this calculator in other epidemic scenarios to see finally how this tool can be changed during a pandemic. So with this slide, I'll finish. And really, the work that we developed in these countries in the region has been very important, and it was an input we needed for decision making. Thank you.
Muchas gracias, William, por su presentación.
Thank you, William, for your presentation. And we heard that the pandemic really changed dramatically many public health techniques, and that led to many significant changes. And we are learning how to improve the systems available. Adriana, you mentioned that you established the Uruguayan health intelligence node. That's a significant step forward, but rather than a new in addition to being a new capacity for the country, how do you see it as compared to other countries in the region? Good. First of all, thank you for your question, because for us, the concept of NISU includes events like this. We see today that NISU, if we were to summarize this in a nutshell, is cooperation in its broadest sense. So even when Uruguay is a small country, we understand that all countries have data that is valuable to share, valuable experiences to share. We all have something that could be of help to others. Whether it's exchanging experience in measuring excess mortality, or an experience as we had using telephones, mobile phones, or offering a labor force. So that is what NISU means for us. It's a space for collaboration to make available to everyone so that everyone can use it. And we hope this experience can be replicated by other countries. The fact that today it's available in Uruguay and this initiative was originated here, well, hopefully that won't be the limit. And it would be good for other countries to either reproduce it or to join us. That's how we see it. Thank you. Pat?
Interesting presentation about how you're connecting communities using new technologies as well. Can you just talk a little bit more about how you keep communities engaged and that process of, you mentioned making sure that the smartphones they have multiple functionalities perhaps, but what is the process of keeping that community engagement for public health surveillance?
Yeah, thank you very much for the question. So the engagement starts from when we work with the community. So we need to identify what kind of whose community want to do this. We don't push them because side note, we are working as a private company. We work with local universities in order to reach into various communities in throughout Thailand. So we need to work with the community that who wants to do this kind of participatory surveillance. So that's part of the engagement. And also we ask them to select the volunteers by themselves. So they can ensure the degree of involvement of both local communities and the volunteer themselves, that they are have high degree of willingness to do the work. And besides installing Facebook, installing messaging application onto the smartphone that we give them, we try to make the system useful for both community in terms of local government and the community members themselves. For example, the toolkit, we name it One Health Toolkit. It sounds like a health-related tools, but it actually can work on the other aspect of community reporting and data collection as well. For example, for some community, they don't have much of the animal suspected outbreak event. So we work with them on adapting the application for the pothole reporting, for the brake street lamp reporting, those kind of things. So it's we try to make the system in their mind all the time, but not always the disease surveillance system. So we try to be flexible and be responsive for what the community needs. And also the engagement of the reporters, the volunteers, is not only ends at the reporting. They also part of the response So the system, as I mentioned in the presentation, that if there are some suspected outbreak happened, we will tell the reporter and surrounding volunteers that there's something happening in this location. You can start doing ABC, and it's quite easy for the community members to do. So that also part of what we keep them engaging. And of course, this kind of work is, in a way, is free, and the community members, some of them felt that this is too much for them. They drop off, which is fine. But some of the community members see this as the opportunity for building the reputation and recognitions. And some of our volunteers became the village head, like elected with village heads, because of they're using our system, and they get being known and being known and recognized by the community members. So we try to not try to reinventing like new mechanism, new incentives, but trying to like piggyback on what the community wants, and which is I have to say different from each community, but we believe that is more sustainable in terms of keeping the community engaged with the system and keep using it.
Great, thanks so much, Patipat. And I know in Thailand is really one of the countries which has the best examples of community engagement when it comes to surveillance for outbreaks of disease. So thanks very much for sharing your opinions. Maybe I'll move on to Karen. And Karen, you gave a fantastic presentation about different approaches to surveillance, things that perhaps we were not doing before the pandemic. And at the heart of that is a lot of different types of AI that I know that you use and have been developing for analyzing these new types of data. Maybe would you be able to talk a little bit more about that AI component that you're using?
Yes, and is this on?
Yes.
Is it on now?
Yes.
Okay. And I dropped my microphone earlier. I really want to be a bit provocative here before we dive in, and just raise of hand by audience members of who is really excited and enthusiastic about industry partners in AI in surveillance. Good, we have some folks. When I was digging into the work we were doing, I have to share that it's a little bit scary when we see industry coming in to help solve these problems, because the mission here is for public good and for public health as well as national security. So we do have a partnership with Google specifically for AI on the data that we're collecting and the data that individuals and corporations and governments share with us. We're incredibly excited about this. We're actually quite optimistic about the outcomes of this. But a key tenet in Ginkgo's culture is twofold. One is that human beings are the ones who are actually doing everything. So even if you're working with machines, it's human beings who are inventing this technology. It's human beings who are sitting at the sequencer. It's human beings who are, interpreting the data and building these systems that AI can kind of exponentially add on to. But the second is that we actually really care, and that can sound like a throwaway, but it's one of our core tenets in our culture is we care how our platform is used. We care about the technologies that we enable. We care about what people will do with the data that we generate. And so in our objectives and key results, we actually have to address caring objectives. So as we build out AI and build out these capabilities on our platform, we actually have a caring committee where we run ideas to, and we have bioethicists on that committee, as well as others, and a culture of being able to speak up and allowing people to challenge us in the public spaces. So our number one kind of the thing that we're like smiling ear to ear at is that there's a lot of things you can do with AI that just frankly a computer can do better. And so let's get the computer in there doing those things better, doing them faster, and then have the human element of sitting down and looking at those outputs, interrogating where the bias might be, being open and transparent about that, and then driving insights from that data by sitting at the table. We meet weekly with our government partners to review the data and generate insights, and they will challenge certain parts of the operations, and then we will go and nimbly implement them. And so you'll see us quite active in the public space. We encourage that kind of pushing and prodding, and that community and global community holding our feet to the fire on how we're going to use AI. But ultimately, we like to move really fast. We like to move really fast. So we're excited to get those types of AI components into our models to just be better at detection faster from novel sources.
Great, thanks, Karen. And I think that's a really important part of the partnership between public sector, private sector, and academic sector is moving at different speeds and maybe pushing the boundaries a little bit, and that feeds into maybe some of the public sector work as well. So it's great to have that partnership. Monica, maybe just to move on a little bit with the work that you're doing in the African continent and across the genomic space, there's been this incredible growth of partnership across the African continent. And we saw that in your presentation about the climate work that you're involved in. How do you go about building that kind of community of trust? Because that partnership really is built on trust, and this huge acceleration of work across countries must take quite a big investment of trust. How do you go about doing that?
Thank you. Yes, so as SERI within Climate Africa, we offer free pathogen genomic sequencing and bioinformatics support to all of our partners, any and all labs in Africa. If they request it, they get our assistance for free, whether it's doing the sequencing for them or sending skilled personnel to them or the reagents, etc. And once we have generated that genomic data or produced that data, we work very strictly with it, that we do not touch it unless explicitly asked by the originating institutions. So we will immediately transfer all of that raw data to them, and we believe that they are the data owners. We're also sympathetic to the fact that they are working under their own kind of policy requirements, ethical requirements, etc. So we find that being very strict in the way that we produce and manage and share the data, it develops trust with all the collaborators within Climate. But also for the data that we produce and own, that's a murky term, but that we own, especially in an outbreak response scenario, we kind of work under like a 3-phase process. So we will very quickly generate the genomic data, and we'll do a very quick analysis. We feed those results back directly to the public health officials and to government representatives before doing anything else with it. So in this way, we develop a lot of trust in our institution from the government and from public health labs. But also we really try to push so far as we can that that genomic data gets used directly for the communities in disease and outbreak interventions from public health officers, so that the use of their data really feeds back directly to the communities that it came from. Then after our public health response, do we publicly upload all of our genomic data. We also make all of our laboratory protocols and our bioinformatic pipelines publicly available. So anyone and everyone in the audience, feel free to go and download some of the genomic data that we've produced. So we work in this kind of open science data sharing way, and we very much encourage our collaborators within Climate to do the same, again, to build trust within the Climate Consortium. It also brings in a lot of partners because they can very clearly see the benefits to working within Climate. But we work in this open science kind of way because we feel that working together collectively as a scientific community really generates great science, but it holds us accountable for the data we are generating and its quality. Only then, after publicly publishing our genomic data, do we undertake the more in-depth analyses for scientific publications and really from the academic gains. It's almost deprioritized in the model that we work. So working in that kind of framework, we find that it really generates trust from the public, the patients that are being sampled, government and public health representatives, our partners within the consortium. But also working in this way and in this open science way, sharing way, we find that it helps us to generate really high impact, good quality science. Thank you.
Great, thanks, Monica. And really, I think South Africa has emerged as one of the leaders in open science for genomics and public health surveillance from the pandemic. So big congratulations to South Africa for that. William, usted hizo la presentación del...
You gave the presentation on vital strategies in Latin America. I know that vital strategies also works in Africa and Asia. How do you see the opportunity of using non-traditional data for public health surveillance in all the contexts where vital strategies operates? Well, actually, during the pandemic, many countries had to make use of different sources of data to understand how the pandemic itself was progressing. We used data from hospitals, administrative data. Very often, the data were not being used so quickly in these epidemic situations. Hospital admissions, occupancy of beds, discharges, and to a certain extent, the data enhance the use of non-traditional sources, and to a certain extent, it feedbacks the use of administrative sources that are very often neglected, specifically on the issue of deaths. This is a job that, although it is true that it has strengthened a lot in several countries in recent years, still in the surveillance systems, except for COVID, where we saw that it's being used, people don't consider it too important. Now, after the pandemic, many epidemiology offices in the different countries are already paying attention, and especially they wanted to establish contact with the civil registries, because if you wanted to see the total mortality rates, you don't need the causes as such, but the total number of deaths, and that's what we're looking at. So one of the challenges is to strengthen coverage of deaths, but while working on everything that has to do with the selection of the root cause of mortality. Thank you, William.
Each of the panelists as a reflection about, we've heard the incredible diversity of work that's happening to strengthen public health surveillance. But let's think about the gaps that still remain, and particularly the gaps that remain for achieving the Sustainable Development Goals. Where do you think we can do better for public health surveillance? Adriana.
Bueno, yo creo que hay...
I think that there are several sides from which you could analyze it, but I'm going to describe what I did the 3 years of the pandemic: alert, preparedness, and response. We've mentioned it during the presentation. If we were asked to choose 3 aspects, those would be the 3. The need of countries to strengthen their core capacities, those elements that we measure annually through the report, the international health rules, to raise awareness among decision makers in the countries, in the governance spaces, health and not health, a comprehensive view, an integrated view, and also to generate alternative plans, contingency plans, and contingency funds, because not all the countries have funds ear tagged for contingency situations, either financial aspects or their capacity to expand the response overnight from bed management, etc. From the in biology, we need to train a critical mass, human capital, well trained precisely on actions for preparedness and response, because it's our responsibility not to expose the healthcare professionals. So that means that we need to train to approach a virus or any other agent while taking care of our human capital, not only from the point of view purely biologic aspect, but also other aspects, including mental health of our staff. And then the proper use of ITs. As we mentioned here, it's impossible to think that we should work as in the past. As my colleagues here have already mentioned, we as epidemiologists, we need to use the time, as the colleague of industry was saying, and we shouldn't fear trusting the tools and leaving the human thought for a new reading. Thank you. Thank you, Adriana. Pat?
One for me, it would be like we should bring the public back to public health actions, because the public health threat is like the threats for everyone. So we should bring the public back to the public health.
Thanks. Karen, from your perspective?
Yeah, I keep getting confused if this is on or off. COVID was able to hijack global transmission routes to have massive spread around the world. With climate change and mass displacement of populations and animals alike, we should expect that places that we're surveilling right now might not be the right places to be surveilling, 5, 10, 25 years from now. And so we need to critically think about, how do we pivot infrastructure in a way that's meaningful, that's science-driven. We had the chance to talk about our colleagues who are working on exactly this predictive pattern ideas of where new nodes should go. And I think if we root too much in today's success in COVID and not realize that major infrastructure changes are coming with climate change happening right now, and don't take these learnings and adapt it to this new system, I think we'll miss the mark. So I'd really like to have a great forward-thinking group, and then also not throw our hands up. This is not immutable, as we were sharing before, with excellent data. We can start to make better predictions and then mitigate risk. That's amazing. So creating a persistent, pervasive surveillance system that's sustainably funded and that the public sees good from in their personal lives, as well as good global citizens, is going to be critical, and politicians who will fund that.
Great, thanks, Karen. Monica, from your perspective.
Thank you. If I could get really specific with it, with the genomic sequencing, genomic surveillance, with our constant engagements with other partnering labs across Africa, so these are public health labs, but also academic institutions, it's the age-old issue of limited resources. So really, as I mentioned, we saw such a huge investment in the technology, the reagents, the capacity building, etc. But we find across many of the labs in Africa, there's typically one part of the puzzle that's missing. There will be maybe just a lack of reagents for them to do the successful sequencing, or there will be the lack of the skilled bioinformaticians. That is a huge gap that we are still facing currently in Africa. And if we could just kind of plug those small, very specific gaps, we could unlock a wealth of genomic data and continue the genomic surveillance programs. But that also speaks to the current issue we are facing now of sustainability, trying to sustain the programs that were set up in the pandemic. Again, not enough funding. And we find that the labs are really struggling with buy-in from national government. If they could get resources and funding from national government, it would support their programs a whole lot. So we kind of need to make that link somehow and convince national governments of its importance. Thank you.
Great, thanks, Monica. And finally, over to you, William.
Gracias. Sí, hemos sido testigos de...
Yes, we've witnessed the huge impact of COVID-19 in the advancements of these SDGs. So we, as surveillance systems, we have a very important job to do to prevent a new epidemic. We should prevent the dramatic consequences that we saw with COVID-19. In the aftermath, in the wake of COVID, we've seen that in many countries, re-emerging or emerging epidemics have appeared. Dengue, chikungunya have appeared in many areas in the world. As a consequence, all the attention that was given to healthcare systems to strengthen surveillance systems, they're not sustainable yet. So if we don't want this to happen again and to see the negative impact on all the objectives, that we need to continue to strengthen surveillance systems and human resources, training people to increase our preparedness for future epidemics.
If there are any questions from the audience or perspectives that audience members would like to share, please.
Hi, thanks everyone. My name's Annie. I'm a technical advisor with a nonprofit that builds technology. And so I'm really curious about the interoperability piece, as I'm sure that was no small undertaking and exercise. These are various data sources and various quality, I'm sure, as well. So I'd love to hear more about how interoperability fed into all of these wonderful initiatives. Congratulations, by the way. Thank you.
Thank you. Do we have one other question or comment? Yes, on the other side. Maybe we'll go and get the answers for the first question. Oh, no. Maybe we'll take the question from you. Thank you.
Hi, everyone. Thank you very much for the presentations and congratulations, because it's amazing all the efforts that you're doing. My question is a bit related to the topic, but not directly. Is if animal consumption is like question in this topic of preventing a future pandemic, if like reducing animal consumption is part of this work that your organizations do. Thank you.
Did you get the question? Reducing animal consumption? Yes, thank you. Would anybody like to offer a perspective on either of the two questions? Adriana?
Well, let me just share the issues related to interoperability. Of course, it's not a simple thing. In the case of our country, of course, that is part of a process. However, Uruguay, well, we were fortunate to be very strong in a number of data sources. And fortunately, we could sketch a surveillance platform that was interoperable, for instance, with the vaccine information system and linking the client to their healthcare provider, because that was already available. The death certificates in Uruguay, not only is it mandatory, but it has a very good quality. So that allows for interoperability, and the interoperability was possible because each of the sources had good quality of data. So it's important to work with the people in charge of that, so to make that dialogue possible, in addition to the resources available for development. But of course, it's not a simple thing, because obviously when the systems were created, nobody was thinking of interoperability, and now that's the main challenge. We know that we wanted to cross data, And even the population is demanding, or other players are demanding, and decision makers are asking us. But not always do the IT people, can the IT people work with that, because they were not creating with that that in mind, and sometimes you have to start from scratch, but it's important to at least start.
Questions about interoperability or reduction of consumption of animals?
I have one comment on the interoperability. This is really not sexy. We set technical guidance and standards, so we allowed diversity within our lab network. But at the height of COVID, we had 67 laboratories supporting at the ready for 10 state programs within the U.S. So we're talking about, we peaked at like 12 million tests in the programs. And so the way we did this was by having qualification standards. So like the partners would have to demonstrate proficiency, a very strong quality management system that regularly checked on those laboratories so that we knew that the data coming out was of high quality. And then fitting everything into a data collection platform that had standards associated with it. And those standards were driven by federal and state standards, with the idea that these will go to GISAID and to other local databases. And so just making sure that kind of level of rigor was there, and it's the boring work, but it's really, really important.
Okay. Pues yo creo que ya.
Well, I think that we've run out of time, so let me now thank the panelists, especially those who came from remote places, intercontinental trips, to be with us today. So I want to thank the WHO PAHO group that are present here. And I'd also like to thank the work of the translators. Thank you for all, and thank you. My apologies, but we have an announcement on the initiative of the intelligence of open sources. This is our initiative, and Uruguay is participating. And at the back, you have some information about this EIOS initiative, Epidemiologic Intelligence of Open Source.